I will try my best. I will try my best that I be able to present things which are useful to them to understand spinal ailments more and be able to spread more awareness of what is happening in the world in spinal surgery, especially at our center, which is at par with any great center in the world in terms of technology, technique, skill, expertise, and handling difficult and complicated cases, which we usually see in India as well as people coming from Africa, because there are many delayed presentations. So, welcome all doctors here. And I would be happy if somebody wants to say a word before I start. Anything about their ecosystem and their expectation from the talk. Else, I will start.
No, so we have Dr. Chiku Abeze. So he is a neurosurgeon and he sees, I think he sees a lot of spine patients at his center. And we have, of course, Professor Daniel, and we have Dr. Stephen Kope from Cameroon. So I think if we can start with Dr. Stephen Kope is a general surgeon, so he sees all sorts of patients. So if we can start Dr. Abeze and Dr. Kope, if we can start a little bit before uh, uh, Dr. Puneet delves into the presentation, it will be great, sir.
Okay, good morning, neurosurgeons, consultants, professors, and all my other colleagues present. It's interesting to have this sort of program, where you have doctors coming from all over the world to listen to this presentation on spinal surgery. Actually, spinal surgery takes most of the volume of the surgical cases in neurosurgery in my center in Nigeria. So, and that's why one of the reasons why I decided to be part of this program. So, we're expecting to see the procedures Professor Venya is using in the management of his patients, and then how those procedures also aid his patients in terms of their recovery. And also, we look forward to see not only the traditional methods, that is the compression, we see the open surgeries. We also like to know how he does his minimally invasive spine surgery, because this is an emerging area in neurosurgery. So, and then we hope to see how he goes about it in the management of his patients and the results he gets from there. That's all the much I can say for now. I leave the floor to my senior colleagues. Thank you.
Great. Um, Thank you, doctor. Thank you so much for letting me know about the work that you are expecting and what you are doing, and also the fact that there is a very keen interest in learning and moving on to minimal invasive surgery and making it a part of routine practice. And I strongly believe that the future lies in spine surgery for safe and effective and efficient outcomes lies in minimal invasive spinal surgery. As we have seen in all other fields, in spine also, I think the minimal invasive spinal surgery ensures that patients don't have to stay long in the hospital, infection rates go down, we can do more precise outcomes. We also have better vision with the aid of endoscopes and microscopes so that we can do a better job, better decompression. The muscle disruption is very less, and patients do not have to do more often than not no blood transfusion. And these patients also gain confidence in the techniques, and this allows us to propagate it all over the world and bring more confidence, because traditionally spine surgery has scared a lot of people, even our own relatives, friends, their parents. And we understand, like knee replacement, spine surgery also is a degenerative phenomenon more often than not. There are, of course, few spinal tumors, congenital defects, but mostly the practice that we do in a private setting is disc related and degenerative spine related. So, minimal invasive spinal surgery helps us to build a lot of confidence in patients and remove the fear away and change the whole perspective of the past, that patient needs to be in bed after surgery and they need subsequent surgeries, or patients will lose motor power or sensory or neurological deficits after the surgery. So it's no more a scary surgery, it's a safe surgery. And I give a lot of credit to technology, not just minimal invasive techniques, but a lot of technology like navigation, robotics, microscopes, endoscopes, and we also use a lot of neuromonitoring in our surgeries. So can you see my screen now?
Yes, sir, we can, but it will help if you make it maximum or on the slideshow.
Okay. Um, yeah, now is it better?
I think there's lag. It seems same, sir. Yeah, now we can see
Yeah,
full screen.
now I think there is a lag. Yeah, I did it. So no problem. We can begin. Means currently I work at Max Hospitals, the second largest chain in the country of hospitals. Varun, I have a small request. Is it okay, like, to continue in English, or will there be a need of translation to
No,
French in
no,
between?
sir. No, sir. What we follow now that we conduct it in English because French translation breaks the flow. But
Hmm.
what we do after the session is, thanks to AI, transcript is available. We give a
Correct.
clean transcript in French so
Sure.
that the doctors can attend now and for certification, and later on we share those clean transcripts, structured academic transcripts, along with a basic guideline based on your talk, sir, which is strictly fiddle to your talk. No
Sure.
editing. Side.
Sure. Means my body of work for the last 20 years has been transformed from open surgery to minimal invasive surgery to least invasive surgery. But by and large, the structure remains the same. That means that we are operating on a lot of discs, we are doing spinal deformity correction. Being from orthopedic background, my tumor work remains around bones, like treating chondrosarcomas, giant cell tumors, aneurysmal bone cysts, and myeloma and metastasis. And I leave my neuro colleagues their expertise. I leave it to their expertise and their wisdom to treat the spinal cord tumors. And we also get a lot of infective spondylodiscitis, tuberculous spine. We also get a lot of degenerative slips, listhesis that we do. So by and large, the work remains the same, but techniques and technologies have transformed over the years, which I will take you through. So I will go through a few slides showing what kind of indications usually we deal with in our practice, and then move on to what we do. Because I'm showing a lot of pictures and videos and x-rays and images, so I think, Varun, that also would be easier across the language barrier, because it's for us doctors and surgeons, it is self-explanatory, those images.
Yes.
So at BLK-Max, we have a team of 8 spine surgeons, and I lead the entire program. I have been with them for more than 16 years. We also have the super specialty education program where we take up spinal fellows through our national diplomat national board exam. Those guys are already postgraduates, and then they appear through for a super specialty exam, and then they enter into a 2-year program where they train with me before they are awarded the national board degree for becoming spine surgeons of future. We also have a dedicated spine operating suite. When I was talking about technology, I will take you through that. And our volume has crossed more than 1100 spinal surgeries in a year, and I see close to 10,000 spinal outpatients. So it's a dedicated spinal department with a very good rehab center for spinal cord injury patients also. But primarily, as I said, degenerative and deformity work, because it's a private setup. So this is our outdoor area where we have set up a center for orthospine and robotic spinal surgery. We acquired the robo for spinal surgery around 3.5 years back, and since then we have performed more than 500 robotic spine surgeries. And over a period of spanning 2 decades, I've done more than 18,000 spinal surgeries. So as I said, my journey has moved from open to an year or two when I was doing it with the loop while I was waiting to have my hands on to microscope. We understand the limitations of buying technology is cost. And since then, I've not looked back, and everything that we have done is that I have done personally is microscopic. But of course, we are moving to endoscopic and biportal endoscopy, modern techniques which are least invasive, even less invasive than microtubular. So microtubular through the tubes, locking the microscope on top of it is what I do day in, day out. That is my core expertise, and most of my work is done through these 18 to 20 tubes, small incisions, and practically we can do all kind of interbody work, degenerative listhesis reduction and fixation through minimal invasive incisions. So spine-related disorders are among the most frequently encountered problems. I think it's only next to headache that patients have backache in their life. Nobody is immune to that, but very few need surgical intervention. Of course, I get a lot of patients from all over the planet, so my numbers are high, and it's also a center which has been set up in continuity for almost 16 years and has its presence. Within the country also, we are hugely populated, the most populous country in the world that way. And moving on to indications of spinal surgery as we understand. So just to classify them into those indications where you need an immediate emergency referral directly same day kinds is Cauda syndrome. We all understand that it's a triad, and Cauda syndrome is where patient has saddle anesthesia, weakness in lower limbs, and difficulty in controlling urine due to tremendous pressure on the lumbar spinal nerves. Patients who have progressive neurological deficit, it may be due to a cervical or a dorsal myelopathy, or it may be due to any progressive retropulsion of an osteoporotic fracture that the cord compression is proceeding and patient is getting worse day by day in terms of his or her walking ability, numbness, and carrying out independent activities. If there is any suspected infection, malignancy, or a vertebral fracture, there becomes a need for emergency referral. While early referrals, which are within 2 weeks, that means we have time, but close observation is required if patient has severe radicular pain with the neurological signs, a sciatica or a brachialgia kind of a pain, lower limb or upper limb discs in the lumbar or cervical area which is compressing on the nerve, or there is a tumor of the spinal meninges, which is like a neurofibroma or a lipoma, which is pressing on the nerves, or if there is a spondylolisthesis. So patient has started having neuroscience, some sort of weakness, gait disturbance, that patient will require an early referral. If there is a disabling pain which is limiting active daily living and you have tried 6 weeks to 8 weeks of treatment, by all means, physiotherapy, medication, sometimes even nerve blocks, that patient will eventually require some sort of procedure because the pain isn't settling. Any moderate motor or sensory deficit which is appeared in front of patient's eyes and is progressing requires a referral. Persistent radiculopathy, as I said, more than 6 to 8 weeks, there's no point waiting. A spine specialist or a surgeon needs to have a look. While routine referrals are more like back pain not improving after 12 weeks of therapy without any radicular pain, no nerve root compression, but we need to find out if patient has desiccated degenerated disc, sacralization, or bifida or spondylolysis. We need to figure out. So they need to be seen by a spine specialist. If there is any diagnostic uncertainty, there may be a spondylodiscitis developing, and that might be a little difficult for sometimes for outdoor practice to diagnose easily unless we refer them to a specialist or there are any psychosocial yellow flags. So these are the patients where patients need to be referred to the higher center for a spinal surgeon or a spinal specialist to evaluate and the need of surgery accordingly wherever indicated. Um, Common pathology groups or specific surgical reference groups are where neurological compression is there, disc herniation with a neurological deficit, spinal stenosis, which is progressive. Patient has severe claudication, unable to walk, which he was doing few months back, and progressively walking distance is going down. Any sort of upper motor neuron signs, that means there is a myelopathy, that means there is some sort of compression on the spinal cord, and that needs to be taken care of. So these are the specific neurological compression surgical reference groups. Then there is another group which is structural instability. Like I said, there is a spondylolisthesis. It can be degenerative, it can be lytic, it can be isthmic. I only operated day before a guy who came from United States with sorry, dysplastic listhesis, was in tremendous pain due to bilateral foraminal stenosis. I did a two-level TLIF and bilateral MIS decompression. He is walking from next day and getting discharged today. If there is a fracture which is causing spinal instability because there is a burst or there is a posterior ligamentous complex involvement, that patient will progress to deformity as well as cord compression, will require stabilization. Usually, I prefer minimal invasive stabilization if there is no significant compression today or there is no deficit. Then, of course, deformity will require stabilization. No scoliosis correction with osteotomies can be done without fixation because they will require a release, osteotomies, pontes, VCRs, pedicle subtraction, correction, and stabilization and fusion. Space occupying pathologies also are reference groups for surgery, especially when there is a epidural compression because of an abscess or a collection in infection, or if there is a osteomyelitis where there is a bony compression also possible, and all kinds of tumor which are causing neurological deficit or progression of neurology will require surgery. So these three categories of patients will end up in surgery. There is no alternative here if you want to prevent their hands and legs from getting paralyzed. So just some case scenarios. I had a 35-year-old girl with grade 3 to grade 4 listhesis, radiating pain of 6 months in the leg, acute exacerbation 1 month, hasn't, no other therapy has helped. Look at this grade 3 listhesis. L5 is sacralized, L4 over L5 slip with a lysis. See the foraminal compression of the nerve. Today we have several options. We can do endoscopic decompression and stabilization. I per se do a lot of minimal invasive work. So for me, doing a TLIF is almost always minimal invasive. Rarely I have to open these patients unless it's a revision where we have to connect to the previous rod. Still, MIS decompression is possible at newer levels. Open TLIF I do very rarely, as I said. Posterolateral decompression I avoid because that can cause implant failure. We need anterior support, 360-degree stabilization and fusion. Also nowadays, there is a sagittal correction that we have to do. We have to restore lumbar lordosis to reduce the stress on upper levels and regain the sagittal balance. So moving forward, patients have a fear of getting paralyzed. They have heard of bad experience of their friends in the neighborhood or when they go and check for similar pathologies being treated in the past. And it's a very common uh, thing of the past that I've seen patients operated with laminectomy alone, wide laminectomy, facetal damage, and patients may get better for some time, but eventually they succumb to instability and they get worse in back pain. So there are things from the past which have changed now over the last 2 decades. I've seen it completely transforming spine surgery, becoming there's more trust in it, and the outcomes have changed, and that has led to tremendous success in spinal surgery. So there is also a worry about life after surgery, and of course there's a cost involved every time you undertake a patient with all the modern technology and investing for finances. So, moving on to the modern techniques and technology, as our colleague has mentioned that what all has changed and what all has made minimal invasive possible is all these modern techniques. I will discuss all minimal invasive tubular microscopic work, endoscopic work, cementing with balloons in geriatric patients who have fractures, disc replacements for younger patients. Unfortunately, the lumbar discs have been withdrawn from the market, but cervical discs are still popular. And of course, advanced instrumentations with good ability to make corrections while doing deformity correction. We have advanced instrumentations which allow vertebral column manipulation and also vertebral body rotation. So these VBR and VCM techniques have given us tremendous ability to correct deformed spines with good ability to restore normal balances. We also have spinal cord stimulators, which are used sparingly for neuropathic pain. Of course, anesthesia has improved a lot with the modern drugs. We can take up surgeries which are 10 hours, 8 hours, 12 hours. So this is only possible with modern anesthetic drugs and advanced postoperative pain management with the patient-controlled analgesia. This has made it possible to be able to do all kinds of advanced spinal surgery work. In terms of technology, today we possess 3D imaging inside the theater, which behaves like an intraop CT. We have multimodal neuromonitoring. We have microscopes of great ability from Zeiss, which gives us the ability to have a magnified and illuminated view of every spinal surgery that I do. I hardly operate without a microscope. And of course, ultrasonic bone osteotomes have also given us the ability to preserve the bone for autografting as well as to make precise cuts around the spinal cord. Our pain management guys also use RF ablation many a time for facetal branch block, for back pain. And of late, navigation and robotics. As I said, 3.5 years ago, they transformed the way we put all our pedicle screws today. So I already told you about multimodal neuromonitoring. It's a part of every deformity work that we do. All scoliosis, kyphosis corrections are done under this. Even all ankylosing spondylitis patients who have Anderson lesion fractures are all operated under this neuromonitoring. We have with multimodal, we have the ability to have NMEPs and sensory somatosensory evoked potentials, EMGs, triggered EMGs. So this gives us amazing ability to stay safe throughout the surgery and being able to locate with precision our steps if at all there is any adversity. As I said, minimal invasive means smaller incisions, preservation of muscles. It's not about skin incisions. It's about preserving our paraspinal muscles, especially multifidus, which is closely associated for dynamic stabilization of our back, less pain because less disruption of soft tissue, faster recovery, enhanced function, early return to work, and hardly any blood loss and blood transfusion required. All these procedures are done through these small tubes. The entire procedure involves putting percutaneous screws through guide wires. Is an entire we need to go through an entire workshop how all these percutaneous screws and The tubular work is done starting from laminofacetal junction, facetectomies through the tube, and identifying the Cambin's triangle, going through that, pushing in the cage. Look at this reduction. Amazing ability from grade 3 back to normal. Um, Complete reduction of L4 over L5. And as you see, these pillars of screws, this is an MIS technique. There's nothing open about it. Look at the cage placement in the center and being able to reduce. This is the final picture. And I operated this patient very recently, last month in February 2026. And look at these incisions to do this entire procedure. 1, 2, 3, 4. That's it. The entire procedure is done through this. No midline big incisions, no disruption, no blood transfusion. These modern screw extenders allow us to do everything in terms of MIS fixation. Of course, moving on to robotics, all these screws we can do MIS, but robotics gives us an extraordinary ability for increased accuracy, safety, save time in the OR, and more important, save radiation, make your theater radiation. All MIS procedures entail a lot of radiation, but with robotics, radiation goes away. It's a reproducible approach and a great tool for patients to have trust. So you can mobilize a lot of patients if you are doing robotics today. Just a small works. It starts with a 3D imaging and it starts with a 3D imaging spinning around the spinal frame, which we have put on the lumbar spine in this particular patient. We are actually obtaining a 3D scan with the frame so that we can register the lumbar spine area and provide this registered CT scan to the robotics software. So once you have done that, then we move to the next step of planning. So once you have this entire this CT on the software, you have a sagittal coronal 3D imaging. You can drag and drop, put your screws in place, and design the way you want to, so that you decide exactly what levels, what entry point, what trajectory. You can throw those screws like in the drag and drop technique. And once you have designed it like this, I want L3 screws like this, L4 like this, L5 or L4, 5, S1 in this particular case. And my rod will be suitably placed here. There's the design that you confirm on sagittal images. At each level, you can scroll them up and down. In axial also, if you see spinal canal is free, here you are looking foramina is free, no screw is touching any nerve nearby. On the coronal image, it is away from the facet joint. So also on the 3D image, you can rotate and see if all my screws are adequately purchasing good bone, the maximum length that you can, and triangulate them, especially in osteoporotic bones. Sorry. So then you bring the robotic arm in action, give them the command. The robot takes the command and projects itself into a trajectory which allows us to put the pedicle screws. If you see here, this screw blue one was the one we planned, and this line is showing that the robo is completely aligned in sagittal plane, in axial plane, because this is the spinal canal, and in 3D image as well as in coronal. It also gives us the ability to put our skin incision through that. So the robotic screen also tells us that what size screws will be adequate for the patient, and also gives us an idea of the length and the diameter both. So once you have that in position, look how completely aligned all of them are. And then we can just go in and throw our drill and screws into it. If you want to, you will hear the drilling. So we are drilling. You have to hand drill through the robotic arm, looking at the screen, because the screen gives you a complete 3D imaging. Here it is a small incision. There's nothing to look on the patient's body. Finally, after drilling, the screw insertion will happen. This is the screw going in through the same trajectory, a few millimeters of cut. And we look at the screen. The blue is the planned one, and the yellow is the one which we are putting in line in on all the views. So the planned and the execution, they are completely overlapping. If you see, they're completely overlapping. That means it's a near 100% precise job. Whatever you plan, robo will align so that you can put it exactly in the same position. So even in revision cases where there is a previous laminectomy, discal collapse, where the landmarks may be a bit of a problem or there may be a slippage, if you are doing freehand, the robotics allow you to plan and put very medial screws and very easily without any radiation, you can do your facetectomy, decompression, put a cage only through two small incisions. Again, I have thousands of listhesis patients operated with MIS techniques. And now, as I said, I've operated more than 500 robotic implantations. Look at this reduction with expandable cage, decompression of foramen. I have done a bilateral facetectomy, very clearly visible on the X-ray. The facet has been removed from both sides with the help of a tube. So it's not an open procedure, but sometimes if there is a previous surgery, there will be a scar. So again, two-level MIS TLIF. I've also done C1, C2 fixations with Robo where the bone elements are small. You can plan your screw on the robotic software, and once you have taken care of its exact positioning on the software, the robo can align and you can bring in your drill, power drill. Only with robo, it has been possible to use power drill to put your screws in the spine. Otherwise, it has never been done before on the in the universe. Only robotic installation gives you that ability. So this is a screw going from C2 to C1 and doing the fixation. Again, moving on from MIS techniques, we have recently started in the last 1 year biportal endoscopy where there are two small ports on the same side of the spine, and you can do the entire procedure like your knee arthroscopy. And instead of using monoportal, this technique gives you the ability to insert your cages and do an over-the-top decompression like your tubes. But here the medium is liquid water, normal saline, and the whole field of view is through the endoscope and not through the microscope. And all this is done nowadays with biportal technique. You can use RF for all soft tissue clearance, radio frequency, and high-speed bursts to do your laminotomy so that you can release your ligamentum flavum. So as you see here, this entire dural sac and roots have been decompressed with biportal endoscopy, and the laminar edges have been removed, ligamentum flavum has been removed only with biportal endoscopy. Well, if some of us understand this is caudal, this is cranial, this is contralateral over the top, the root on the other side, and ligamentum flavum being removed from the opposite side, two small cuts, all discectomies, all T-lifts can be performed through biportal endoscopy. We also have a lot of patients. I do 15 to 20 cementing for geriatric patients, almost a procedure every day. Patients have either osteoporotic fractures or they have secondary pathologies like a malignancy, metastasis, sometimes myeloma that leads to collapse and severe back pain. Cement provides them immediate ability to stabilize, and it is done under local anesthesia. So it's a daycare procedure. Patient comes with a lot of pain either to your clinic or to the emergency, but can walk out of the hospital same day because they get tremendous back pain relief. So patients who have either PLC involvement or a burst fracture or a pathology which involves instability in the entire vertebra may require fixation, MIS fixation with cementing. Here, cementing alone will not work because of the burst fracture. All the edges are broken from all sides. So it's better to fix them and put a cement through that. Lumbar canal stenosis, traditionally, there was a laminectomy done, which leads to a lot of additional instability. Now, all these procedures we are doing with over-the-top decompression through the tube. So we preserve the facet on ipsilateral side as well as contralateral side. And like any decompression, we go to the spinal laminar junction, decompress the ligamentum flavum on our side, retract the dura, go on the other side, drill the slope from the base of spinous process to the opposite lamina. You see the drill going all the way, and then remove the flavum at the end, and your thecal sac and both the nerve roots are completely free. You can retract the opposite nerve root as I showed you in the biportal endoscopy. So your spinal canal diameter increases significantly, almost 8 to 10 times without compromising your facets. No need for fixation. These are called unilateral laminotomy, bilateral decompression from one side. So you've entered from here, you have decompressed this as well as the opposite side. So these are patients of lumbar canal stenosis. You can use a uniportal endoscope, you can use a biportal endoscope, you can use a tubular technique. So we don't do anything open here. No spinal canal stenosis is dealt with open technique, especially 1 or 2 levels. Wherever there is instability, fixation required, you can do a microtubular facetectomy, decompression, interbody cage, and fixation. Wherever there is no instability, only decompression, preserve the facets, do a midline decompression over the top, either with a uniportal technique with endoscopy or a biportal technique, or like I do every day is a microtubular technique. So all three techniques can be used. We also use a lot of expandable cages to restore the height and lordosis in lumbar spine, and that has been a boon. This is one of the expandable parallel cages initially, but nowadays we have 12-degree lordosis in our cages. So that has given us extraordinary ability to restore the spinal balance. So few cases of spinal deformity before we can have an interaction uh, uh, on case-to-case basis or whatever our routine practices, we can discuss anything related to spinal surgery. So scoliosis and kyphosis corrections are very close to our heart, and our entire spine center comes from orthopedic background, even though we don't do anything else but spine for last 18, 19 odd years. So, but being from orthopedic background, scoliosis and kyphosis correction is inherent to us. So we do a lot of work on spinal deformity correction, both in children as well as adults. We all understand the telltale signs to detect scoliosis clinically. If the shoulders are imbalanced, one shoulder is higher than the other, if the head is not centered above the pelvis, if there is an appearance of a raised prominent hip on one side, or the waist is uneven, if there is a change in look or texture over the spine, like some hairy patches, color discoloration, skin discoloration, or any dimples, or leaning of the entire body. We call it leaning tower of Pisa, leaning of entire body to one side. So mostly patients who are more than 40-degree curves will require surgery, especially if they are presenting before skeletal maturity. So they need to be closely watched with X-rays every 6 months. If they cross 40 degree, they need to meet a spinal surgeon and get it rectified immediately. So we get all kinds of patients. We get congenital, we get idiopathic, we get post-COX or post-trauma sequelae. We also get a lot of ankylosing spondylitis. We get neglected deformity. We get post-tubercular kyphotic sequelae, and I get a lot of revisions to be done in deformity who have been operated in the past. I'll try to show you a few cases. This is a 10 years old female from Africa who came to us with a post-tubercular, almost 90-degree kyphotic deformity. somewhere in the mid dorsal spine, maybe D6, 7. I don't remember exactly. We did like 2 years back, 2.5 years back. So this child had spastic paraparesis, started having dribbling of urine when she presented. She had tuberculosis when she was 6 years old, which was treated conservatively, and she developed a deformity because tuberculosis with at-risk signs in children less than 5, 6, or 10 years are still growing children. So the TB may get arrested with medication, but the growth leads to progressive deformity. And when she presented with a sequelae. That means TB was healed. There was no wet disease, but progressively the kyphosis was worsening, which led to cord stretching and thinning and deficit appearing and progressive deficit. So we did a vertebral column resection. We removed the entire vertebra from the front. This is a difficult surgery because patients present very late. It's not a wet disease. You can't just pull it up and make it straight. It requires 8 to 10 hours doing a two-level laminectomy, fixation in a kyphotic spine in the right place, then doing a vertebral column resection, decompressing from both sides, removing the entire vertebral body, putting in a cage, making the spinal cord completely free, because your outcome will depend upon decompressing the spinal cord as well as stabilizing, but most important, deformity correction. So all these three goals were achieved, and within 6 months, she started walking from wheelchair-bound life, which was progressively going on to be bedridden life in future. She is now getting back. Her urine control has come. Children have extraordinary ability to recover if they are taken care of spinal cord compression. So another child who came with early onset scoliosis. Children who are very young and have curves which are like 60, 70, 80 degrees. They cannot be delayed till skeletal maturity. So we do a growth rod, which allows us, this is a modified Schiller procedure where we arrest the convexity on one side, and then we have put few screws at 2 or 3 levels above, 2 levels below, and put translating rods with a connector which allows the child to grow so that the child can also gain height and at the same time arrest the growth on the apex of the convex while continues to grow on the concave side. Everything is done under neuromonitoring, so all those signals are very important. Some other scoliosis patients which come to us early, like this child came at the age of 11 years, had a flexible deformity. Look at the correction, like complete correction. So it also depends if they come in time or they come neglected late, like 17, 18, 24 years, 30 years. I have all kinds of patients. I have patients operated at 48 years too for something that they were suffering for a long time. So look at these deformities getting corrected, shoulder balance, hump getting restored. So some other congenital scoliosis patients see this hump because of hemivertebra which was neglected, and we had to do a vertebral column resection. See before surgery this 10-year-old child, and see after surgery. Had we left this child alone, you can understand, you must have seen many roadside neighborhood children who have neglected their deformity due to various psychosocial, economic, and awareness reasons, and they end up having a very bad hump on the back. This child is cured for the rest of his life and can live a normal life from here on without any worry of getting paralyzed in future, progressive deformity, cosmetic appearance, even psychological confidence regained. This child's life changes after this surgery. It will take 10 hours for us. It will require precision, all kinds of technology, neuromonitoring, and a very good teamwork and a good apex center. But we can provide all that to patients referred from anywhere in the world. Springel shoulder, another deformity, which is cervicodorsal. This is at D1. Look at the scoliosis and kyphosis. So she has scoliosis as well as kyphosis, and bad one, very bad one. We corrected with again a vertebral column resection procedure. Look at the restoration of cornal balance as well as sagittal balance. So she's done great in terms of her outcome. Again, multiple level laminectomy, decompression, corpectomy, putting a cage in the front. This entire procedure may look very small on the X-ray, but it's a long surgery, requires around 1.5 to 2 liters blood loss at times. But at least 800 to 1000 ml of loss is unavoidable. One of the complex cases, again, neglected dorsolumbar junction hemivertebra. She presented when she was 16 or 17. Imbalance in the shoulders, scoliosis, bad kyphotic hump. Hemivertebra could have been excised at the age of 4 or 5 years. They should be operated early, but children usually come late because of lack of awareness. If you ever see a hemivertebra at a dorsolumbar junction and patient having any sign of a deformity, the patient should be referred soon. The surgery will take 3 to 4 hours. Hemivertebra can be excised and small fixation can be done, but unfortunately, they present when very late when they have full-blown deformity and kyphoscoliosis. We need a vertebral column resection and correction. We use ultrasonic osteotomes, as I said, to cut our bone precisely. It gives us the ability to retain the graft, and it doesn't heat up the area because it's associated with irrigation, and it doesn't make cuts like a chisel or a hammer into the pedicle or bones which we need to preserve. So this is the kind of correction you get, and day two post-operative, sorry, patient is up and about on their feet, walking with no neurological deficit at all. So some other patients we get nowadays, as I told you, last 5 to 10 years, I'm getting a lot of revision patients. So patients operated in the past. This is a surgery that has been done from S1 to L5, 4, 3, 2, L2 to S1 fixation. Patient presented with upper motor neuron signs and patient presented with paraparesis. Patient was neglecting, thinking it was something from the lumbar, but that's not true. You have UMN signs, don't neglect them. It was something higher up at 5, 4, 3, 2, 1, 12, 11. Between D11 and 12, there is a cord edema, swelling. So there was an instability going on. When we went in, we found the upper two screws were loose, and we had to extend above and do a two-level decompression, D10, 11, D11, 12, because there was some ossified ligamentum uh, flavum, which we call it yellow ligament syndrome, OLF, that had to be excised. And thereafter, from a wheelchair paraparetic life, she is getting back on her feet, has started walking within 4 to 5 days, and is gaining back her neurology very fast. This child is very close to my heart. I operated recently. She is 24 years old when I operated. She had been operated in the past. If you see, there is a scar. She was operated in her country at the age of 12 years. And she had an idiopathic scoliosis, which was not difficult to treat. But unfortunately, there must be some limitations with the surgeon and the surgical team and the hospital. They could not achieve what was desired, and there was a continuous shoulder imbalance, there was a hump, and this child felt that she couldn't get the outcome, and she was studying spine books for the last 2 years, understanding what kind of osteotomies can cure her. We had a very lengthy discussion for an hour and a half because she knew every kind of osteotomy, she knew every kind of correction that is possible, and she wanted the best this time, and she had waited another 12 years. She's 24 today when I operated a revision surgery. So bad hump, shoulder imbalance. This is what was done by the previous surgeon. If you see, they stopped at the apex, did not go all the way correcting, and they put a couple of hooks. I know putting in apical and periapical screws in scoliosis is a challenge, but somehow they could not get the desired outcome. They stopped at the apex with a couple of hooks. There is no density of screws around the apex. They did not go all the way up to the upper dorsal, and that led to fusion mass. If you see, there is a fusion mass, completely one rod like a femur bone, completely one bone, because children fuse very fast once you disrupt their tissues. And after that, it started worsening from here, the shoulder imbalance. So this is what we had in hand with a lot of implants. We had to do the correction, scarring. She's very thin, syndromic. She's 24, looks like 15 or 12. Limited blood volume because she was only what 39 kgs in weight. So we didn't have much options. We were restrained, very thin pedicles for us to engage, but we did our best. We went all the way up, did multiple osteotomies, and did a correction. We found reasonably good shoulder balance for her. We could make her walk on day one post-operative after the surgery. And today she looks much more balanced. Her hump is gone. She's very happy with what she has achieved for the rest of her life. So I end my presentation here with a lot of gratitude to everyone. They have left their families on a Sunday and listening to this experience I have gathered over the last 2 decades, 21, 22 years. I have been doing this spinal surgeries, and we have been able to put up a lot of work together and present in all national international conferences as and when we get an opportunity. And we are very gung-ho about the biportal endoscopy. Maybe next year when we meet, we will be done by around 800 to 1000 biportal endoscopy cases. I will give you a specific presentation only on endoscopy. I also invite a lot of my colleagues who are keen on observing, because I get fellows from all over the world, and to come and spend a few weeks, few months with us and see. Like recently, I had a fellow from Nepal. That guy saw 25 surgeries in just 1 week because he was a practicing surgeon at National Trauma Hospital. But I showed him all kinds of robotics, spinal deformity, endoscopic cases, minimal invasive T-lift, listhesis reduction. So a week's time, you can see 20, 25 odd cases from all kinds of pathologies in spine. So thank you very much for the august audience to patiently hearing my talk. And I now invite any questions, any discussions. Please come forward and have a discussion on your practice, what you want to change, or if something good that you are doing, I will be more than happy to learn from you. Thank you so much.
Dr. Puneet, thanks for such a detailed talk. And I can sense that you're not feeling 100% today. Your energy level is different today. Are
No,
you
no,
well?
no, I'm okay. I'm okay. But I think we have been very busy and sleeping very less. So Sunday
Okay.
becomes a little lazy in the evening. Yeah.
Okay. So, sir, we have a case that Dr. Innocent from Kenya wants to discuss with you.
Sure.
He's sharing reports, so we will document the case file, and if patient agrees, align it with your Connect Clinic drive on 23rd of March.
Okay.
Sir,
100%
one,
okay.
but before anybody asks, I have a question. So this fellowship thing that you mentioned,
Yes.
many doctors in our network, they talk to me,
Mhm.
and with our long association with you and experience of so many happy patients, if
Mhm.
you are accepting fellows, please
Mhm.
share with me the selection criteria, like what you look for, and if they can come and join, sir, we would be very glad if this can be extended to doctors in our
See,
network.
yeah,
They can learn
sure.
a lot from you.
Correct, correct. So, see, practically there is no selection criteria here as far as you are coming in as an observer. So, as an observer, at best, what we can do is make you scrub and observe. And one cannot participate in performing the procedure. But I think it's a great experience in today's world when everything is available on the internet to just go and observe. That's where the next level of journey starts. So we can accommodate for 1 week to as long as like 8 weeks to 10 weeks if anybody can um, make that kind of a space in their practice. So I also feel that there are two ways people can engage from their department. One is the senior guys who like to come in for 3 to 5 days or 1 week. They are already into practice. They want to take it to another level by improvising on some techniques or understanding the nuances and finer things. And then there are students who are working with them who can come for longer periods and have an understanding of the same. All these are not accredited by any national board. They are, at best, we can provide is a certificate from our own hospital and signed by myself and our management body. Apart from that, all the certified courses happen through national exams. So that is a minimum 2-year course, or there is a Spine Society of Delhi, Spine Society of India fellows who come in for like a month to 3 months, and one of the fellowship is for 1 year. But they are not available for overseas trainees or fellows or visiting surgeons.
So I understand, sir, observership is something, which is feasible considering
Correct.
the logistical
Correct.
constraint. So do they need to be surgeon or even general practitioners can come? Who would
See,
benefit?
anybody can come in. It all depends on their interest. As far as they are doctors or paramedics who want to come in, I also get a lot of technicians who want to learn from our technicians how the equipment can be used more efficiently, how the equipment can be uh, used in a uh, with better modern upgradations. So it depends, like, with what interest they want to come in. Any doctor is welcome if they feel they have an OPD practice, outdoor practice, clinic practice where a lot of spine patients come and they want to refer them. They need to be updated on what is done, and when you see it, your belief becomes stronger. Till the time we have not seen it, it's very difficult to fathom in your head and be able to convince your patient and tell them that if you will do this, this will happen. When you then they see it will, so they will help it in this way, but they will not help it in their surgical practice. While all the surgeons who want to elevate their practice would have to come in and observe the surgical procedures more closely with us, and can have we can develop a long term relationship, maybe set up their centers in future with Jivo, and help them tackle more cases themselves there, and wherever there is a complex case, complicated case, they can always refer it to us.
Okay. So, sir, there is a patient case note shared by Dr. Innocent Zili from Kenya. So, a diffuse L4 L5 disc bulge compressing the bilateral transversing nerve roots,
Mhm.
left paracentral L5 S1 disc protrusion, narrowing the left lateral recess and causing a spinal canal stenosis of 9.5 millimeter. And now then
Right.
there's a comment that he's a 32-year-old male afraid of surgery. So this is a very common counseling problem that we encounter.
Yeah, very, very common. See, usually if it is a 30, if he or she is a 32-year-old, and there is no significant back pain, no instability, we prefer to do a decompression procedure. Like I showed you, a unilateral laminotomy with either you can do a biportal endoscopy, so there will be 4 to 5 millimeter to 1 centimeter, two incisions at two different places, or we can do MIS tubular. There will be a 2.5 centimeter incision in one place, and we can do a decompression. If there's a huge disc, we can do the discectomy at the same time. If the patient has significant back pain and dynamic X-ray shows instability, or there is a lysis or a discal collapse with foraminal stenosis, that patient will require a T-lift. That means we'll have to put a cage and 4 screws and stabilize it and create discal height, as well as decompress the bilateral foramina with restoration of spinal balance.
So in this case, sir, what I mean, should I share this message with you on WhatsApp? So maybe when I was reading,
Sure, and if possible, share the images also.
we have asked for the images, sir.
Yeah,
So
I have
based on the
requested.
message information shared, sir, what looks like to be the your recommendation here?
I mean, if the patient is already exhausted, medicines, physiotherapy, not getting better, I know he's afraid of surgery, but I'm sure he needs a surgery because he's suffering, and that's why he's hanging around Dr. Innocent and other doctors for a while and wants to get treated.
Okay. So we have a compliment from Dr. Stephen Cope. He's from Cameroon. He's a general surgeon. And thank you
Okay.
for a very impressive and interesting presentation. We have some more compliments also. So from Dr. Ivan, He said,
Oh, I haven't
today
opened the
it's,
chat. Now I am looking at it. If you want, I can read them.
yes, sir, you can start
Yeah,
from Dr.
so I
Ivan.
think Dr. Davis Kinari said, looking forward to understanding how minimal invasive surgery is done since in Kenya we do only. Dr. Kinari, I would request if we can spend time together. If you are planning to come to India, please come to Delhi to our center. I tried my best, but that's what all you can do in 45 minutes or 1 hour because it's a 20 years of body of work with a lot of technology. I think you have to observe more work, and that would actually allow you to move on to minimal. It's not difficult, but everything that you want to start new in your practice is always uphill, a steep curve, but very much achievable, very much achievable. Looking at MIS centers in the world today. Good evening, Dr. Ivan, and good afternoon from Dr. Sunday Ucha from Nigeria. Wonderful. I mean, I'm glad people from Kenya, Nigeria. Um,
Dr.
I have operated. Yeah, I've
Uh,
operated a lot of patients from Nigeria too. Dr. Ivan says, today it seems we were not leaving any stone unturned, so detailed. Great, I'm thankful. I hope you liked the presentation and could get some useful tips or useful information out of it. Good afternoon, Dr. Brian, Dr. Innocent. Thank you for the compliments. Yeah,
Dr. Puneet,
this,
I wanted to introduce Dr. Brian. He is
yeah,
also, we have created a country chapter in Zambia.
from
So
Zambia,
he's
right.
the CLP coordinator for Zambia,
Mhm.
Jivo. So Dr.
Yeah,
Brian is a senior doctor.
yes. I would suggest, Varun, that you have a group with them or it's very important because patients, as and when they come, they should be able to share the reports with you immediately so that as and when my availability is never an issue. Means by the end of the day, I'm available and I
It's
usually
never
don't
an
think,
issue, but you are also busy in OT a
yeah,
lot of time
yeah,
every
yeah,
day.
yeah. That's
Your
okay
surgery
for a
schedule
couple
is
of
also very
hours.
busy.
Yes. Yes, 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 yes. But I usually reply the same day before going to bed, most of the queries that I get. And I do get a lot. I get 30 to 40 every day from all over the place. So, Dr. Brian, we look forward to working together in some way, helping your patients from Zambia, at least with providing an opinion, if not more than that. But we also look forward to treating. Varun, I think you must be considering some physical connect also later during your program, right?
Yes, sir. So, sir, in 2026, our focus is also like we are in a very advanced stage of dialogues with multiple hospitals in different countries.
Correct.
So, uh,
Correct.
and the idea is that we first build that working relationship with them and specialists like you through these Connect Clinic drives. And the idea is, sir,
Correct.
like you and I discussed long back, that the what you feel, and I have a strong conviction that when a patient travels to India, we help one patient. But if we
Yes.
organize a surgical camp there, which whatever is possible, we help 10 more, 10 times more with the same
Correct.
effort. So we are working towards that, sir. That is the end objective. And like
Correct.
more clinical penetration so that more patients can benefit. So
Yeah,
whatever
I
we
completely
discussed
agree.
long back, sir, that is like we are working on our part on that, sir.
Yes. Thank you, Dr. Stefan, for your kind words. I hope it was useful for you in some way. And Dr. Davis Canary, I think this is overwhelming for me. A lot of good words from everyone. I look forward to interacting in person. I'm a, I'm, I'm a people's man, so I like to meet people. I do take a lot of talks, but I think at the end of the day, personally, if you ask me, what helps is interacting on one-to-one basis and understanding, because to each their practice is very different. And Dr. Martin Mavaura, I don't know where are you from, but thank you for
Kenya.
your pardon,
So
Kenya.
more
Wow,
more.
super, super, super. Yeah, I look forward to. I think a lot of doctors here from Kenya, and Kenya is a very progressive country. I've been there a couple of times, but before COVID, I haven't visited after COVID. Dr. Okitundo, great to see you here. Thank you so much for being with us today.
So,
Uh,
Dr. Okitundo is Professor Daniel, sir.
yeah, I know, I'm aware. And Dr. Divine, thank you so much. Dr. Mabairi, thank you. Lovely to see you guys, all of you. I think your compliments and the chat box tells that nobody has left the room finding it boring.
So your interactions are never boring, sir. Dr. Puneet, given this, what I want is that after Connect Clinic, we have scheduled Connect Clinic, but if I can find a day for you, probably we can have an interaction with the relevant doctors in the Jivo network, informal
Right.
interaction with you
Yes.
and the doctors outside the masterclass system, sir.
Correct.
So,
I think, see, in my office, I get a lot of time between the surgeries because one patient goes out and the next one comes in. There's a great window in between, and we can always do a one-to-one connect with a lot of the doctors and understand what are the requirements they have in terms of progressing their centers or the kind of patients that present to
I
them.
think that would be very necessary.
yes,
Ah,
Dr.
Dr.
Sanjay, yeah,
Sandy,
please go ahead,
yes,
sir.
please go ahead.
Yeah, my own is just to commend his goodwill for the good presentation and how informative the presentation was. And if we can keep in touch, more and more presentation like this, we will be happy to, because we have a lot of patients here in Nigeria where we can communicate.
Thank you, Dr. Ucha. Like it means it requires a lot of dedication on your part too on a Sunday to be actively present. And I congratulate Jivo and I also admire them for their efforts that they have to put. It's very easy for me to come and sit in front of a computer and present from one of my rooms, but it takes a lot of effort to get all those people together. So Jivo must have put, and Varun, Soumya, their entire team have put a lot of effort for a month or more, maybe. I think that they have been preparing to get all of you on board. So I congratulate them. I think there must be a hand of applause for them for their efforts. This is incredible.
Yeah, I had a lot of over 1,000 invitation, but you know, Sunday is always a busy day, so most of them from Nigeria came from my invite. So it's a good one. Keep it up with you.
But Dr. Puneet,
Jivo is
we
doing
also admire Dr. Sunday. He's one of the few
Jivo is
doctors.
doing very well.
I think Dr. Sunday, like while I moderate, barring an exception, he attends almost every masterclass. That is
Very
also,
nice.
I mean, there are many doctors here which are very regular, and the
Hats off
hats
to
off,
your
sir.
commitment, Dr. Sunday. Hats off to your commitment.
Hats off to him, sir. It requires a lot of commitment and that regularity, taking time out on a Sunday. But Dr. Puneet, you're forgetting it's not a month's effort. I think today yours is 80th masterclass. 80th in the last 2 years. And
Oh
you are
man.
doing third time, and every time you have picked up a different topic.
Yeah, superb. So, Dr. Biniam, thank you so much for being there with us today, and thanks for your kind words. Uh, Dr. Sunday, we have already spoken to, and we are in awe of you. Um, Dr. Divine, yeah, great that you found it practical. I try to keep it like that so that you don't lose the interest in the theory because the doctors is a mix. So everybody have their own kind of practice and varying fields. So cases are easy to understand, and that's what we encounter in our daily practice. So it's a very functional presentation. It's not a very theoretical presentation. And
So you've forgotten my professor here, Professor Ngozi is also here. He's been always here. Dr. Mberry, Dr. Ono, and so many of them here. So they've been very committed.
Thank you, Sunday. Thank you, everyone. And well done to the presenter.
Yeah, good evening, Dr. Gozi. Good evening.
Good evening,
So
sir.
He's
while
a
before,
he's a professor of medicine. So
I think we have multiple professors today. I think
yeah,
before we wrap up, I wanted to, although we have shared this information with all of you, that I mean, at Jivo, we take a structural view of solving things so that expertise of excellence Indian surgeons, I mean, just saying excellent is not doing justice, and they are actually leadership of Indian healthcare, like Dr. Puneet, who have who have done this, who have built this minimally invasive surgeries and early adopter globally, and who have built centers of excellence in India, and who can replicate this globally. So what I want to the other apart from this master class, the other structural thing that we have designed and envision is this Jivo Connect Clinic. The concept is simple. We are just doing it digitally all across the globe, all across the world, but this happens within a country. Like from a smaller facility, sometimes a doctor, a more experienced doctor, they physically visit once a month or something. Like Dr. Puneet visits different cities in India. He goes to Dehradun, ONGC, which is a big public sector undertaking, first Wednesday of every month, and he has a lot of patients lined up. That's how he consulted my mother also, who has a spine issue. So Jivo Connect Clinic is just an extension of that. I mean, Dr. Puneet is very supportive of Jivo because the way we are building it from a healthcare perspective and doctor network, we can regularize his Connect Clinic for Jivo doctors, a monthly schedule, so you can align relevant patients and his expertise comes to your clinic. So a lot more patients can benefit that way. And
Correct.
but this month, his slot is on 23rd of March. I mean, I requested him, I chased him. He had a lot of travel planned, already agreed, and so that's why we agreed on 23rd of March. So the only expectation from you is that uh, you identify relevant patients, shares reports with us so that we can share it with Dr. Puneet and his team well in advance. And all those relevant cases will be, we'll communicate the slot with you. And the other part is you should use this Connect Clinic drives to promote your local practice also. Like if you communicate the creative that we shared about Dr. Puneet, a lot of patients in your network, they are not aware today that you can help them this way. But if you do it, maybe not this month, but next month they may approach you. And using these connections and collaborations, this will help you in your local practice also. Because once the patient community knows, people need help. It's just that they don't know where to go. So once they are aware that you can, on demand or on call or on minimal time difference, you can you can connect with surgeons like Dr. Puneet. And I'll share that Dr. Puneet has operated like dozens of our patients, international patients so far. And in every case, no matter a follow up is required after 6 months or a year, he always gives a time slot. Surgery may haven't happened a year back. A busy doctor does not have time. And no matter has Dr. Girdhar said, okay, I'm going to charge again for this consultation. I mean, the only rare
No,
exception.
uh, I think there is a lot of trust and faith required for somebody to get up from Africa, come all the way to India, and trust you for what you do here. There's not much that they can do about it. So, apart from being honest and ethical about whatever you do, I think it's very important that we have a close follow up and be able to understand their complaints or their concerns or any issues thereafter. So, once they go back, if they ever need, I think Jivo is also very proactive on this, is that they organize those video calls or connects with them for regular follow-ups. I think which makes all the difference to somebody's treatment. It's not just one surgery, it's the entire program. They have to be rehabilitated into the society back from where they came in a crisis situation. So we are with you, with all our doctors. We are with the patients, and I do a lot of video connects, almost 5 to 6 every day, all over the world, for my patients who need surgery. So I talk to them before, and I also talk to them after.
So Dr. Puneet, after this, like maybe in the coming few days, I will reach out to you. We will spread the communication in our network. So at least those doctors who see spine patients regularly. So maybe we can have a focus group rather than a master class. Let's say 15, 20 doctors from network who see whether they're neurosurgeons or orthopedic surgeons who see regularly and an interaction with you, one to many interaction,
Yeah,
a close forum so that they can also get guidance about when to get in touch with you. So Connect Clinic is one thing, Masterclass is one thing, but I think we can have this focus session. And those doctors who maybe need a more frequent one-on-one thing with you, we can coordinate that also. Thank you, sir. Thanks a lot for your time, and thank you, everybody. Again, I'm sharing the Connect Clinic announcement again with you. So 23rd, please mark it on your calendar. 23rd March is the Connect Clinic Drive with the Pune. Ideally, the patient cases and reports should reach to us by 21st. If they reach to us by 21st, we'll be able to share with Dr. Puneet. Our team will get time to share with Dr. Puneet in advance and we'll communicate the consultation slot to you. You should be present in the consultation so that the patient gets a joint consultation from you and Dr. Puneet. And if any relevant patients for treatment in India, I mean, at least they'll get first right guidance. And if any intervention is needed, if they can be managed locally, Dr. Puneet will guide you. If they need to come to India, if it's absolutely necessary, they will get that guidance also. And if you feel that, if you miss out the deadline also by 21st of March, no worries, you can share it after that also. We will request Dr. Puneet's availability for relevant cases. And based on his availability, they can be aligned for a consultation later on also. Uh, Let us make these drives successful so that this can become a regular feature and the real structural change. Like, I even don't like the term medical tourism. It's such a misnomer. It's not tourism, it's cross-border care, and it can happen. The entire continuity care spectrum can happen only when doctors in Africa like you and specialists in India like Dr. Girdhar, they have a way to collaborate on different aspects, and the patient gets that continuity. And that's what we are building here at Jivo. Our job is just to build this structure so that all the doctors like you and specialists like Dr. Puneet, they have a forum. So you're sort of a virtual hospital together rather than a physical hospital, and this collaboration can continue lifelong as long as you practice.
great.
Uh, Thank you, everyone. Thanks a lot.
Thank you. Thank you, Dr.
Dr. Puneet, with
Oronaya.
your permission, can I end the session?
Say again?
If I have your permission, then I can end the session now.
Sure, 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 sure. Means if anybody else, we can ask if anybody else has any
If anybody
question.
has any question that you want to ask now, even if
Dr.
it comes
Onu,
later to you to
also
share
from
on the group.
Nigeria, I would like to thank. Yeah. Where is Dr. Oronana from? Oronana Paul.
Nigeria. Nigeria.
Oh, fantastic. Thank you so much. Dr. Onu also, Dr.
Dr. Onu is also from Nigeria.
Oh, wow. A lot of doctors from Nigeria.
Yes. Okay.
So thank you, everyone. Have a great evening and look forward to the Clinic Connect next time. Thank you, Varun.
Thank you, sir.
Thank you, Jivo
Thank
team.
you, thank you, thank you. Appreciate
Thank
it.
you. Thank you.